Hello, my name is Oren McKayley, and I'm the maker of Medical Espresso. Please take a moment to read the disclaimer. If I've used any images that you've created and they've been used inappropriately or if you have not been cited correctly, please send me an email ASAP so I can fix the error. Thank you very much. Please enjoy the lecture. So it happened. We're going to study the adrenal gland and all of its confusion and all of its gloom and doom. But hopefully if we approach this in a stepwise manner, we kind of take a step back and draw it out, I think we can all figure this out. So essentially what we're looking at here is we see a picture of the brain, right? So we have the hypothalamus over here, we have the anterior pituitary, and that's what we're going to care about right now because basically we have CRH, which is corticotropin releasing hormone, and that is going to be released from the hypothalamus. Okay, now that's going to be released by a few different things, right? So essentially, stress will cause us to release CRH. We could also have interleukin 1b that could also cause us to release CRH. So it's a whole bunch of things out there that are really going to make this happen. And the CRH itself is going to work on the anterior pituitary, right? So we've released our CRH, right? Then our CRH goes to our anterior pituitary. Then our anterior pituitary is going to cause a release of ACTH. Now, granted, a whole plethora of things are about to happen, but this loop really only pertains to cortisol, because what's going to happen is that cortisol will inhibit the CRH. It's going to inhibit our ACTH, right? So it's going to have a loop back, basically, on both of these. So keep that in mind, that that's really the function here. It's all about, so ACTH, right? So remember, we have this whole loop over here, right? ACTH is over here, and then it goes to the adrenal gland. The adrenal gland is broken up into the cortex and the medulla. Adrenal corticotropin hormone, right? So you're going to go to the cortex, hence cortico. The medulla, we'll talk about that another time. That's where you're going to make your catecholamines, so your epinephrine, norepinephrine, right? You know the deal. The cortex, on the other hand, we're going to get all of our other fun stuff. So we'll talk about our sugar control, we've got our salt, we've got our sex, right? All that fun. This all starts off with cholesterol. That's really the whole basis of this picture. Now, ACTH is going to come along, it's going to activate something called cholesterol desmolase, which is the first enzyme in our pathway. Now, I mentioned this ketoconazole, just throwing a farm tie-in. So if you see that, ketoconazole is going to basically be used pharmacologically, so it's going to decrease the cortisol production and things of that nature, now you know why, because it does have a direct effect. It's not abstract in any way, shape, or form. Now, the cholesterol desmolase is going to change cholesterol into pregnenolone. I have a hard time saying it. That's the last time you'll hear that come out of my mouth. Now, pregnenolone, that was wrong, is it's going to come out of my mouth a few more times, I guess, is going to be changed by 3-beta-hydroxysteroid dehydrogenase, and it's going to be turned into progesterone. So once you have progesterone, that's going to be changed by 21-beta-hydroxylase, right, which is going to remove the hydroxyl from the 21-beta site, and that's going to change it into 11-hydroxycorticosterone. So, just follow with me, and it's a headache, so it'll take you a few times. Then we'll have 11-beta-hydroxylase, which will change hydroxydecorticosterone into cortisone, right? So now we have our, most basic of our steroids. Now, here we have aldosterone synthase. Can you guess what that does? Well, it's going to change our corticosterone into aldosterone. Now, that can be upregulated by angiotensin 2, downregulated by angiotensinogen 2. So, we're not really going to focus on that too much, but I just want you to kind of realize this because you have your renin, angiotensin, aldosterone axis, that whole, that controls your blood pressure. So it's something you need to keep in mind. So what makes the granulosa so special is really going to be the enzymes, right? And that's really what separates all of these regions, the granulosa, fasciculata, reticularis. For example, I'm just going to circle a few of these right here. So I want you to realize what I'm doing here. What I'm circling are going to be the enzymes that are only going to be in the granulosa. So we have cholesterol desmolase and aldosterone synthase. That's why aldosterone is only made in the granulosa. Okay, now once we get to the fasciculata, we have a few of these overlap, right? So what's going to be the difference is the fasciculata will have these three enzymes right here, but they will not have these guys. Okay, no aldosterone synthase, no cholesterol desmolase. So that's going to be the big difference over there. And once we get to the reticularis, for example, now we're going to lose our 21-hydroxylase and our 11-beta-hydroxylase. So there is some overlap, but it's all about the enzymes. So once you get to reticularis, you can't make hydroxycorticosterone, you can't make corticosterone, you can't do any of that. So I want you to realize that these enzymes are not present everywhere, and that's why this picture at the end of the story is going to look the way that it does. So back to 17-alpha-hydroxylase. So what exactly is that going to do? Well, basically give us 17-hydroxypregnenolone, 17-hydroxyprogesterone. But these, aren't terribly high yield to really know. I mean, you kind of want to focus on some of these. You'll realize aldosterone's important, progesterone may be important. You want to know the byproducts. Exact names you can pretty much guesstimate by the time your test comes. And then we could also get to enzymes through different processes, right, in the different regions. So as you realize, see what's happening there? So our 3-beta-hydroxysteroid can also come along and act on this, and we get this. So, just keep in mind there's all these different ways we can get everywhere. Let's clear up that mess. 21-beta-hydroxylase is going to give us 11-hydroxy-decortisol, right? So, we want to get to our cortisol while we're making it there. And the bottom line is that happens with 11-beta-hydroxylase. And there we go, right? So just think about this as a whole way that we're going through this, okay? Now this all happens with fasciculata. We have one more region we're going to get to, and that's going to be the reticularis. So that's how we're going to really get our sex hormones going on. So we have our 17-hydroxypregnenolone, and that's going to give us DHEA. Okay, so the DHEA with our 3-beta-hydroxysteroid dehydrogenase will give us androstenedione. Androstenedione can take one of two trips, but right now we're going to focus on the fact that it becomes testosterone, right? The testosterone can then become either DHT using 5-alpha reductase, which is present in the adrenal gland, or it can escape as androstenedione, can escape as testosterone, and in the fat cells it will encounter aromatase, which will make estrone or estradiol. So those steps, there's a reason I didn't put them inside those boxes, and that's because it's not happening inside the adrenal gland. And that is the end of this section, I believe. Okay, so we're over the hump. That first part was really the boring part and the painful part. Now we're going to get on to some of the deficiencies, a little more interesting stuff, things that you may or may not see as a clinician, but you need to know regardless for the test. So the first one we're going to talk about is 17-alpha hydroxylase deficiency. And I want to focus on the word deficiency for a second because you really need these enzymes to survive. Okay, like if you're not making any aldosterone, if you're not making any cortisone, if you're not making any sex steroids, you're not going to live. So you have to have something. It's just deficient, right? It's levels of deficiency. So it's a whole spectrum. So in females, if you have 17-alpha hydroxylase deficiency, you're going to lack secondary sex characteristics. If you're a male, you'll be phenotypically female because once you don't have that 17-alpha hydroxylase, you're no longer able to make your testosterone and like all that other good stuff. So you'll have like pseudo-hermaphroditism, like weird external genitalia, undescended testes, all that stuff. And in both men and women, you'll have hypertension, right? Because you're basically going to have a whole bunch of aldosterone, right? And what's aldosterone going to do? Aldosterone's going to bring sodium in and potassium out. Focus on those words: sodium in, potassium out. Aldosterone, sodium in, potassium out, right? So you're also going to have your low DHT because, well, I mean, you can't really make your testosterone. So, and you'll see that in a second, right? So here's your whole chart, right? Now we're going to get rid of our alpha hydroxylase, right? Getting rid of that. Peace out, right? And we're stuck. So this whole thing really makes no difference in my life anymore, does it? Right? I mean, maybe we get some of this going on, but other than that, all of this stuff is really just useless. So that's really how we get that kind of a presentation. Essentially, is really all that's functioning here. So we see just the granulosa. Forget about the rest of it. The next one we have is a 21 alpha hydroxylase deficiency. Right? So I should have put a little alpha in there. How's that going to appear? So that's going to have some salt wasting and vomiting in infants. Children will have precocious puberty. They'll have, for females, they're basically going to be dudes. Right? That's simple as that. And they're all going to have hypotension. They're all going to have hyperkalemia. They're all going to have increased renin-angiotensin. And what you look for as your test, you're going to want to look for 17-hydroxyprogesterone. Okay, so really what you're looking for is where's this whole thing get stopped up, right? So if you have too many substrates, right, think of the Chatillier's principle, if you remember that from chemistry, right? So if we're missing this over here, then everything kind of has to flow this way, doesn't it? Right? And that's exactly what happens. So you're going to be missing your aldosterone, you're going to be missing some of this corticosteroid, and it's really ugly, right? So you're going to be pumping out testosterone nonstop, right? That's really what the bottom line is here. 11-beta hydroxylase, not quite as bad. I mean, you will have female virilization because you're going to have more substrates going in that direction, and you will have retention. But again, it's not quite as extreme, so we're looking at something a little bit friendlier because again, think about it, where's 11-beta hydroxylase? It's right there, okay? So you're going to have more hydroxycortisol, and that's really going to relieve some of those issues over there. And 11-hydroxycorticosterone, you're also going to give you some mineralocorticoid activities going on. So you have a little more function than you otherwise. And this is basically going to be the picture you're looking at, right? So what did I say? 11-hydroxycorticosterone, 11-hydroxycortisol, whole bunch of testosterone. Sorry, ladies. That's what happens. Again, just to reemphasize, it's going to increase our blood pressure. Done, okay?